Hello everyone, a very good evening. Today let's discuss on iron refractory iron deficiency anemia. So this iron refractory iron deficiency anemia, it is a autosomal recessive condition. This lies with a defect in both absorption and utilization of iron. So there is a defect in absorption and utilization of iron. So what is the etiology behind it? What is the mutation that is causing your iron refractory iron deficiency anemia? So the mutation that is being involved in this is a loss of function mutation in the gene called as TMPRSS6. What is this TMPRSS6? So this TMPRSS6 is a transmembrane serine protease 6. I write it here. It is a transmembrane serine protease number 6. Fine. So when there is a loss of function of mutation in your TMPRSS6, it causes a dysregulation in the production of hepcidin. So there will be a dysregulation in the production of hepcidin. So what is this hepcidin? How is it being involved in your iron absorption and its utilization? So normally this hepcidin is being produced by your liver. So this is produced by your liver and it is a regulator of your systemic iron balance. So it is a regulator of your systemic iron balance. So when your hepcidin level is too high, it will decrease the absorption of iron from the intestine. Okay. So it limits the export of your iron from your intestinal enterocytes. So normally in a child with a iron deficiency anemia, so normally in a child, non-normal child with iron deficiency anemia, this liver will respond by decreasing the hepcidin production. Okay, your liver will respond by decreasing your hepcidin production in a child with the iron deficiency anemia. That is, for example, nutritional iron deficiency anemia. Okay, supposing if in a patient with this iron refractory iron deficiency anemia, your hepcidin level will be too high. Your hepcidin level will be very elevated, or circulating levels will be too high. That will be leading to the impaired absorption of your intestinal iron. So there will be an impaired intestinal absorption of your iron. Not only that, this will also impair the utilization of your parental iron. So there will be an impaired utilization of your parental iron formulations. So this parental iron formulation will require your macrophage for its processing before the iron can be made available for your erythropoiesis. So that will not be made sufficient when a child is having a iron refractory iron deficiency anemia. Okay, so when you take a lab investigation, this child will have a severe hypochromic microcytic anemia. So child will have a severe hypochromic microcytic anemia. Along with this, the child's ferritin level also will be very low. Okay, so this hypochromic microcytic anemia, meaning the child's MC level will be between 45 to 65 ml. Okay, and the child will have a transferrin saturation of less than 5%. So even though the child has this severe hypochromic microcytic anemia, so the child's normal development, that is growth and your neurocognitive development and growth will be normal. Okay. So next investigation of choice to confirm your diagnosis is by sequencing. of your TMPRSS gene. to establish your genetic diagnosis. So this will be your investigation of choice to establish the diagnosis. What is the treatment for this condition? Treatment is oral iron cannot even be used because of your impaired intestinal absorption, but you can use a parenteral iron formulation. This will increase the iron level in the blood, but it will slowly, but what it cannot be utilized together for your erythropoiesis. So the hematological counts, your HB and MCV and all, they will take a very slow rise. Okay, so the treatment is you have to start on only with parenteral iron supplementation, but you should be careful for your iron overload also. So the parenteral iron therapy, this will raise the body iron stores, and the hematological response will be very slow. Why? Because your macrophage processing that should be made available, so this macrophage processing should be there to make your iron available for your erythropoiesis, but this macrophage processing will be impaired in the patients with your iron refractory iron deficiency anemia. So your hematological response is usually very slow and it is not complete. Response is very slow and it is not completely correct. Okay, this is regarding your iron refractory iron deficiency anemia. Thank you.